Greetings. My name is Dr. Rick Alcorta. I'm the State EMS Medical Director at MIMS. Today we're going to be talking about the emergency medical services as it relates to the Molst program, the medical orders for life-sustaining treatment. What is EMS? Emergency medical services has to do with all pre-hospital care providers. That's both public safety and commercial ambulance services. They both are recognized as EMS operational programs. One of the most important things to realize when you're dealing with EMS providers is they're focused on time-critical out-of-hospital emergencies. And they respond when you call 911 or when you call for a commercial ambulance service to respond to your facility to deliver care to one of your clients. There's a need for immediate care when you're dealing with the 911 public safety services. Those EMS providers, when they arrive, they're prepared to take care of a patient in a matter of minutes and really are focused on life-saving interventions. So it's real important that they recognize whether this patient is a code, do everything to the patient, resuscitate them, or they're a no code. Means they don't want to do CPR, and yet they can get medical assistance depending upon what's going on and what their decisions are. This is not the time for a long discussion at the bedside to discuss whether this patient is an appropriate person for CPR or not, or is a code or a no code. This is the time to be able to provide the patient information to an EMS provider. And what they want to see is they want to see that page 1 of the Molst form. Now, page 1, section 1, is going to deal with whether the patient is a code, an EMS DNR A1, A2, or EMS DNR B, which is palliative care. Page 2 does not, I want to repeat, does not apply to EMS field providers, and therefore they don't care what's really on page 2. But trust me, they'll look at it. What is the medical orders for life-sustaining treatment, the Molst program? Well, Maryland has had a EMS DNR program for almost 20 years now. This came into fruition with the Healthcare Decisions Act that went into place and charged MIMS with establishing a standard statewide EMS DNR program. The current Molst form has incorporated that EMS DNR program into its page 1, and that's why it applies not only to EMS providers, but to all healthcare providers. It contains critical patient care information, particularly on page 2, and that's why it's very important that hospitals, nursing homes, hospices, healthcare facilities, home healthcare facilities, and specialty care transport services pay close attention to both page 1 and page 2. But again, remember, EMS field providers are really only going to focus on page 1 of that Molst form. Do current Maryland medical protocols for EMS providers still apply? The answer is yes. The page 1 of the Molst form is exactly the same as it is in the Maryland medical protocols for EMS providers. So when we look at the implementation of the new Molst form, which went into effect October 1 of 2011, the page 1 information is the same. So when we look at the old EMS DNR form and the new Molst form, they're parallel. They match up so that an EMS provider and other healthcare professionals understand what the patient's wishes are and what the orders say on the Molst form. We will also be recognizing the old EMS DNR forms. They do not expire. So for example, you may have had a patient that you took care of, and that individual patient has a Molst form at home or has an EMS DNR form at home. Both of those forms do not expire. Ideally, we would like those that are in a healthcare setting to have a Molst form. That means if they've got an EMS DNR form, maybe 5 years old, 2 years old, 6 months old, they should be transitioned to the new Molst form. That way, not only do you have the EMS DNR information, but you have pertinent information on page 2 for other life-sustaining treatment orders. Besides the Molst form itself, EMS field providers and healthcare professionals can recognize an EMS DNR bracelet or necklace that meets the needs of only page 1 of the Molst form. So this is section 1, page 1, full code, EMS DNR A1, EMS DNR A2 DNI, EMS DNR B. Physicians and nurse practitioners can recognize this. Ideally, we would like to see the entire form whenever a patient is picked up by EMS or public safety. So please make sure both page 1 and page 2 of the Molst form are completed, because myself as a practicing emergency physician, I want to look for that form so I know what I need to do for that patient in an emergency setting in a real-time basis. And I don't have to go through about 1.5 inches, 2 inches worth of nursing home documents looking for pieces of information. I can have it all in one place. That's really one of the big advantages of the Molst form itself. There are some choices to be made. And what we want to look at on section 1 of page 1 is whether the patient wants to have a full resuscitation, CPR, intubation, ventilation, ventilator settings, or they don't want to have any CPR, and then what level of medical resuscitation do they want to have? And that's A1, intubation, A2, do not intubate, DNI, or option B, which is really palliative care. So let's kind of walk through those so that everybody has a clear understanding. What is attempt CPR? Well, realistically, attempting CPR is providing all medical measures to resuscitate somebody who has stopped breathing or lost a pulse. It also means they're going to get everything to keep them alive while they're still breathing and have a pulse. So they will basically get the full armamentarium of EMS, emergency department, hospital-based resuscitation in an effort to keep somebody alive or revive them in case they've lost the pulse or stopped breathing. This includes intravenous access, medications, defibrillation, intubation, and ventilation. So attempt CPR really is aggressive resuscitation and doing all things possible, appropriate all things possible, to keep somebody alive or to bring them back. Now the next choice for an individual really is, if I don't want everything done, do I want CPR? And if I don't want CPR, that means once I've lost my respirations or I've lost a pulse, we're going to withdraw care. What that really means is we're not going to do CPR, we're not going to intubate you, we're not going to ventilate you, we're just going to withdraw care. So once you've stopped breathing, we are not going to do any further resuscitation in an effort to bring you back. And there are really 3 options here. And the reason for 3 options is not everybody is the same. Many patients that have reversible underlying conditions, diabetes for example, will want to be able to receive D50 to bring their blood sugar back up. Whereas other folks that are approaching end of life may want to have nothing done, even though they may have diabetes. And those are the choices they get to make working with their physicians. So let's start with option B. Option B is really palliative care only. I want to make something clear here. That is not no care, it is palliative care. So it's comfort care. So this includes, from an EMS perspective, the administration passively of oxygen. So somebody's got to be breathing, they've got to have a pulse, and we can give them oxygen, we can control bleeding, and if they have significant bleeding, we can actually put a tourniquet on if we need to get proximal control so they don't bleed to death. We want to make sure they're positioned comfortably. So if they've sustained a fall and they've got an angulated fracture, we can splint that angulated fracture and put them in a position of comfort, take them to an emergency department where they can appropriately take care of that injury. Now, one of the nice things that we have is we're focused on removal of pain. Many times in our end-stage conditions, especially with cancers, there's a lot of pain involved. And sometimes oral pain medications are not enough, or an individual sustained an acute new injury, such as a fall and a broken hip. That individual may not be getting enough pain relief with their oral prescriptions. So when you're thinking of the call to EMS, and this patient is an option B patient, and yet they are having a lot of pain, you may want to make sure you notify the 911's public safety answering point, the 911 center when you call them, that this person's in a lot of pain, because morphine is carried by our advanced life support providers, not our basic life support providers. And most 911 systems for an EMS DNR B patient will send basic life support. So this becomes part of the challenge that you as a healthcare facility want to make sure you have a familiarity of your patient, familiarity with what their orders are, in this case option B, palliative care, and they've sustained an injury that currently is not managed with their current pain meds. So that advanced life support could be dispatched and give them morphine to control their pain. The other thing that when they're in option B is sometimes we don't always transport to an emergency department. We can actually transport somebody to a hospice facility where they can then move into that next phase of life and get supportive care through the hospice programs. Now there are two options for option A, and this to me is probably where most of our patients want to be. Options A mean, one, remember this is a no CPR category, but options A are basically two things that speak to treating underlying conditions. So what does that mean? That means we're going to do everything we can, with minor exceptions, to keep somebody from losing their pulse or stop breathing. So we're going to give them meds, we're going to give them IVs, we can give them oxygen, and the difference between EMS DNR A1 intubation and EMS DNR A2 do not intubate is that one includes the ability to be intubated if you're still breathing and being put on a ventilator, and A2 DNI means if you're breathing, we are not going to intubate you even though you may be in congestive heart failure or respiratory failure, and you will never end up on a ventilator. That's the big distinction. Many patients are terrified of ending up on a ventilator for the rest of their lives in a very uncomfortable, uncontrolled setting. So let's touch on what's really involved here. Many of our patients have underlying treatable conditions: diabetes, congestive heart failure, COPD, things that are really reversible or can be improved upon. A diabetic, for example, if this person is a diabetic and they're an EMS DNR B, or Molst form B, that patient cannot get an IV and get IV dextrose. EMS cannot do that because it's not part of the protocol. Therefore, when you talk to your diabetic patient, you want to probably talk to them about options A, because they're going to want to get that D50 to correct their blood sugar, bring them back up to normal, and then treat their underlying condition. Same applies with congestive heart failure. We have patients that go in and out of respiratory distress, in some cases respiratory failure, that may, and this is their choice, may need intubation. If so, they would like to be an EMS DNR A1. They may not ever want to be intubated, and then it would be an EMS DNR A2 DNI. But most of our patients who have treatable underlying or reversible conditions should be EMS or Molst form A1s or A2s. So let's talk about the distinction between A1 and A2. What's involved? Keeping in focus now that we're in the no CPR category. That means if a patient stops breathing or loses a pulse, none of these things are going to be done because that patient is going to be allowed to pass peacefully. They don't want thumping and pumping going on. That's the big focus for the no CPR categories. Let's talk about option A2. Do not intubate, DNI. Most of our patients are going to probably want this category. They do not want to be intubated or end up on a ventilator. This is the category they want, and yet have their underlying treatable conditions addressed. So what kind of care are we talking about? EMS field providers are able to administer oxygen via cannula or a non-rebreather mask, but they can also administer CPAP and BiPAP. Oh, wait a minute, those are ventilator settings. Well, no, they're really not. What basically these are is the ability to support somebody's breathing by giving them a little bit of pressure. CPAP stands for continuous positive airway pressure, and BiPAP is bidirectional positive airway pressure. But the patient has to be breathing in order for this system to work. It is not a true ventilator setting. So explain that to your patients so they understand that when they're taking a deep breath in, this just makes it a little easier for them to breathe. It does not breathe for them and does not mean, quote, they're going to be on a ventilator. So in this case, we can give them CPAP or BiPAP And actually, it has reduced EMS intubations by almost 50%. Every advanced life support system in the state of Maryland, both public safety and commercial, carries CPAP. They don't all carry BiPAP. The commercials do, but the public safety does not. What else can we do? EMS providers can start an intravenous, or in a very egregious situation, start an intraosseous. They actually use a bone drill, usually in the humerus, or actually most commonly in the lower leg, so they get IV access and a rapid process to give fluids and medications to resuscitate somebody. We can give the whole armamentarium of EMS medications to resuscitate an individual, and we can do 3-lead and 12-lead EKGs. So we can identify where somebody is actually having an active heart attack or not. And oftentimes in a public safety setting, they can transmit that ahead to the emergency department so they're prepared to meet the patient. Now, you notice cardioversion. Well, that's actually shocking somebody. Well, that's only if they have a pulse present. So if we have somebody that has a heart rate of 200 and a supraventricular tachycardia and the medications have not slowed it down, or they're in a pulse-present ventricular tachycardia, we can synchronize cardiovert them, shock them, and get them back into a normal rhythm. But if we shock them and they go into asystole, where their heart basically stops, remember, once we lose a pulse, we withdraw care. So we would be at resuscitating, cardioversion, successful resuscitation, great, they're back in a normal rhythm. Or if they go into asystole or lose their pulse, we withdraw care and we are done. We let them pass peacefully. Now, we can also apply external pads that can cause and generate a pacemaker process. So without putting a central line in, we're actually able to start pacing somebody with a pulse-present bradycardia. So for example, a patient goes into a ventricular rhythm, heart rate of 50 or 40, and they're hypotensive, we can start by giving them an external pacemaker. Let's say somebody's in respiratory distress though, and they have respiratory failure due to pneumonia, due to COPD, due to congestive heart failure. We can do all the things above to try and help them stabilize and correct, but we're not going to put an endotracheal tube in their airway and put them on a ventilator. That's the big distinction between option A2, D and I, do not intubate, and A1. So let's talk about option A1. Option A1 basically means we are going to do everything to keep you alive, keep you breathing, as long as you have a pulse and are breathing on your own. The moment you lose one or the other, we're done. But what we can do is all the same we can with option A2, D and I, but at the very bottom you notice we're going to insert breathing tubes and assist the active breathing of the patient. So if you have COPD, your patient does, you have congestive heart failure, those are conditions that may require intubation for a short period of time, which would be ideal for this category because they have a reversible condition, may need a period of respiratory resting, if you will, where they have to be intubated, placed on a ventilator for a period of time, giving them all the meds and resuscitation and correcting their pneumonia, and when that's corrected, they can then be extubated, taken off that ventilator. So that's the big difference between A2 DNI and A1 with intubation. Again, remembering CPAP and BiPAP are not ventilator settings because the patient has to be actively breathing for those settings. Just makes it easier for them to breathe. When you are, as a physician or a nurse practitioner, writing these orders, or nurse, or somebody at the nursing facility that's reviewing these orders, you've got to make sure you keep your doctors on track. What does that mean? Well, that means that Section 9, where it says other orders, cannot contradict any of the other 8 sections, especially Section 1 on page 1. Why is that so important? You can't have a cafeteria menu with full attempt CPR, full code, option A1 intubate, option A2 DNI, and option B palliative care. They can't say, well, tweak this, or we're only going to do this during the resuscitation. Cannot conflict. So when you're reviewing those orders after the physician has interviewed the patient or the care decision maker, Make sure those other orders do not conflict with any of the above orders 1 through 8. What EMS providers are going to be looking at is Section 1, as I've referenced before. And it's very important that we make sure there is one of these options selected. If a patient really doesn't want to select an option, it is a default to attempt CPR because that's currently the standard of care in the community. So if somebody doesn't wish to have this discussion, which they're totally allowed to have, the answer is the default is attempt CPR. Now, many of you practice in a nursing home facility or assisted living, and the first thing you do when a patient gets into distress is to call who? Ghostbusters? No, you call 911. Well, that's absolutely appropriate, unless this person is a Molst form A1, A2, or B, palliative care, no CPR. Because if they've lost a pulse or stopped breathing and they're a no CPR, you shouldn't be doing CPR, and public safety is not going to do CPR. So why are you calling 911? Allow the patient to pass peacefully. So please make sure you have the ability to identify your patients quickly with a Molst form and identify whether they're attempt CPR, and in that case, do everything, including CPR when they lose their pulse and stop breathing. But if they're an A1, A2 DNI, or B, no CPR, and they've stopped breathing or lose the pulse, don't call EMS, because we're not going to do anything for that patient because we're going to allow them to pass peacefully. Now you have to know EMS field providers are going to look at both sides, even though side 2 does not directly apply to them. Because on the back side, under 4C, there's a section that says, do not transfer to hospital, but treat with options available outside the hospital. And that's what the EMS provider is going to look at and say, why are you sending them to the emergency department? Well, nursing facilities, assisted livings don't have a lot of medical assistant capability, x-ray capability in some places and others not, medications in some places, others not, and certainly can't be doing intensive care resuscitation in these nursing facilities. So if there is a 4C box checked because the patient wants to stay at your facility, maybe you're a specialty nursing facility that can give them lots of resuscitation, but they've gone ahead and sustained a fall, fractured a hip or a pelvis, that's not something that you can treat in that facility. Explain that to the EMS field provider so that the EMS provider doesn't go off and report it to the Office of Healthcare Quality. The key here is they're going to look at that form. So if you have a 4C checked on that Molst form, explain it to the provider that this level of care can't be provided at your facility. Patient needs to go to the emergency department. In an effort to reduce conflicts between EMS providers and nursing facilities and assisted livings, it's important that you take a look at that Molst form so that you know that an EMS provider is going to recognize and accept it. If you come upon a patient and they don't have a Molst form, it's important that you get one. If they have a Molst form but it's not signed, it's an invalid form, especially on page 1. Realizing you can sign in the bottom of page 1 for those orders, and there's a signature spot for the nurse practitioner or physician on page 2. The key piece here is make sure it is signed. I would also recommend that you keep the original and send a copy or a Xerox. EMS providers, healthcare professionals will accept and recognize a Xerox copy of a Molst form. Molst forms do not expire, as well as old EMS DNR forms do not expire. EMS can also recognize a bracelet for the options under Section 1, page 1, CPR, no CPR, and which option if there are no CPR. The drawback is it doesn't address any of the life-sustaining treatment orders on page 2. When we look at the Molst form, it's important to make sure that there is a physician signature, ideally a printed name, and the physician or nurse practitioner's identification number, because remember, this form is going across the continuum of care, from a nursing facility to an EMS unit, to a hospital, to a commercial ambulance service, back to a nursing unit, or maybe an extended care facility, or even back to home. And that form is traveling with this patient at all times, We want to make sure we can identify the physician or nurse practitioner who's written the order and make sure it's current. Remembering, if you have more than one form, it's the one that is most recently dated that is empowered. That older one should then be voided out as you've been taught in the program. As you're aware, the Molst law has gone into effect. The reality is the regulations are in the process of being promulgated, and when they are implemented, everyone that is required to have a Molst form must make sure they have it within 6 months of the implementation date of the regulations. EMS field providers may be asking politely, that's what they should be doing, for the Molst form. Explain that they either do or don't, and if they don't, do they have an EMS DNR form to make sure that that's to go with the patient so we know what level of care we're supposed to take care of. Again, remember, time-critical intervention is how EMS providers are focused. These are type A personality folks. They're basically there to save lives. That's what they come in and do. So you need to kind of make sure you give them the form quickly so they know whether they're doing CPR or they're not doing CPR. Now, about 6 months after the regulation implementation is when EMS providers are going to be asking those that are required under the law to give them a Molst form. If not, they're going to be providing this information to the Office of Healthcare Quality because this is a major concern because they want to make sure they're doing the right thing for their patients. Do you have any questions? At this point, I apologize. I'm not there to answer them personally for you, but there are some experts there that can answer the questions. Thank you very much.